स्टार्ट है नहीं इसको फुल स्क्रीन
उसका नहीं है सर
नहीं इसको पूरा है नहीं ठीक अरे okay why isn't it coming in the display mode पूरा में क्यों नहीं आ रहा इसको लगा अच्छा चलो ठीक है okay my dear friends today we continuing the lecture on malaria and we will be we'll go through what we covered earlier was the epidemiology of malaria and how the agent, host, and the environmental factors which are involved. We also told you that how malaria was rampant right through the South Asian region. How we went through a stage where we are, and today where we have not so many cases of malaria in our country. Though still, any person who suffers from fever, one of our primary diagnosis we should consider as malaria. So, going further, let us, as we said, malaria is one of the major public health problems in India. And India used to report 1 million cases. Now, of course, we are come down to lakhs. And main cause of just a short revision, we know that in India we have Plasmodium falciparum and Plasmodium vivax, most common species. Plasmodium vivax is in the plain areas and falciparum mainly in the hilly areas or forested areas. We've already spoken about the life cycle of mosquito. Please remember the life cycle. The two distinct varieties, Plasmodium vivax and Plasmodium falciparum. Plasmodium vivax has a persistent hepatic phase. This is very important to remember these things because when we talk about the treatment is guided by these particular, by the life cycle of the Plasmodia. We need to remember that we have to kill the Plasmodia or the merozytes when they come into the circulation. That's number one. We have to stop this persistent hepatic phase. That means we have to kill at the hypnocyte stage. That is one thing which we need to go against. And third is when the mosquito picks up the gametocytes, then only it can propagate the disease. If the gametocytes are killed, we will not have the disease being transmitted by the mosquito. So, three things that we are going to target when we have to look at treatment for malaria. All these three stages are dealt with by different drugs. Rather, two of them dealt with by one drug. We'll talk about it as we go by. In the past, chloroquine was effective everywhere and we had no problems. But as you keep using a particular drug, you will find that the organism starts mutating and then decides how to fight this particular drug. So, this particular, we have many areas where chloroquine is, falciparum is resistant to chloroquine, especially so in the northeastern region. So, what are the clinical features of malaria? Clinical features of malaria is classically fever with chills and rigors. So whenever you have a fever, you have headache, myalgia, arthalgia, anorexia, nausea, vomiting. These are symptoms which come on with any sort of fever. Symptoms can also be non-specific and mimic any viral infections or enteric fever. Malaria is suspected in patients in endemic areas or recently visited endemic areas. So you would expect malaria. Suppose you go to the northeast and you get a fever, we expect that possibly it is a plasmodium falciparum malaria. The most in a person with fever, not before pre-COVID times. Let's not talk about COVID times. Pre-COVID times, one of the first diagnosis which comes to mind for a person who is in India is if a person has fever with chills and rigors, the first diagnosis which comes to mind is malaria. Second diagnosis which comes to mind is dengue. And third is any other viral fevers. So, of course, we have to look at the history of the patient. We have to see whether the patient is having any burning while passing urine that we're thinking of urinary tract infection, whether the person has an upper respiratory infection, whether he has a running nose or he has um, various other features, cough, which we'll talk, which we can then think of respiratory infections. If all these features are not there, the first diagnosis which comes to mind in our country is malaria, followed by dengue. Also, of course, in our country, we have to, for chronic fevers, these are for acute fevers. Chronic fevers, then we start thinking of tuberculosis and various other diseases which are there. We'll not talk about it today. So, as such, the fever of malaria goes through typically through three stages. Basically, why does the fever come? The fever comes whenever there is a merozoite shower, whenever the merozoites are released. Called a merozoite shower, a shower of merozoites coming into the system that results in fever. Now, this fever can be of will be of three stages: the cold stage, the hot stage, and the sweating stage. Now, in the cold stage, the person generally gets a headache, nausea, chills, rigors. Typical chills and rigors. You feel much more colder than your actual temperature. If your temperature is high and you're feeling cold, then you can consider that possibly it's because of the difference in temperature between the environment and the person. But the chills and the rigors is a feeling of shivering which is there. Person asks for more and more blankets. The chills and rigors, a rapid rise of temperature, and parasites can be detected in the blood. The best time to take a sample for malaria is when the fever is high. Please do not tell the individual you take your paracetamol. I'll come in later on and take the slide. Take the slide when the temperature is high. Take it the best time you'll be able to get maximum number of um, various, various stages of plasmodia in your slide. May last for up to an hour. The next stage is the hot stage where you have an intense headache and hot and dry skin. This lasts for 2 to 6 hours. The fever may go off automatically without any paracetamol also, and this goes off with profuse sweating, and then the skin is cool and moist. This lasts for about 2 to 4 hours. Now, whenever a person has chronic malaria, they have a splenic enlargement, and as I told you earlier, a spleen is palpable only and only when it is enlarged 3 times. So, in chronic cases, there is a splenic enlargement, and because of destruction of the blood cells, there is anemia. The complications which are there are cerebral malaria, renal failure, dehydration, and gastrointestinal symptoms. You must, as I told you earlier, we must consider the other causes of fever: running nose, cough, other signs of respiratory infections, diarrhea, dysentery, burning micturition, skin rashes, infections, abscesses, painful swelling of joints where you're looking at arthritis, ear discharge, lymphadenopathy. All these should be considered and be ruled out before you try to decide for malaria. All clinically suspected malaria cases should be investigated by microscopy or rapid detection test. Rapid detection test. We'll talk about it later. Now, a treatment for malaria aims at complete cure, prevention of progression of uncomplicated malaria to severe malaria, prevention of death, interruption of the transmission. That means what we're talking about interruption of transmission is the gametocytes being killed. The rest of it, the treatment, when you treat it early, you'll stop uncomplicated malaria, you'll prevent deaths. And minimizing the risk of selection and spread of drug resistant parasites. You see, we must stop it early so that the drugs, the plasmodia do not become resistant to this. You keep on giving drugs just like that, you will find various areas becoming resistant to drugs. So what do? We do microscopy. We have already studied that in when you did your microbiology. You take thick and thin smears. Please remember, rapid detection tests are not the gold standard. Microscopy is the gold standard for confirmation of diagnosis of malaria. The sensitivity is high. It is possible to detect malaria parasites even at low densities. You can quantify the parasite load, and you can distinguish between different species of malaria parasites at different stages. All these things can be done in microscopy. You have studied this well in microbiology. But just for a revision, we remember that you have to do a thick and a thin smear. The thick smear is for the searching for the parasite. A thin smear is to identify the species. Please remember that. You have done that earlier in microscopy. Please remember. You must have also done a fluorescent antibody test, and that fluorescent antibody test we do only when we require for epidemiological studies. There are these rapid tests or dipstick assays which are there, which initially came up only for Plasmodium falciparum. We now have for Plasmodium falciparum and then for mixed malaria. We'll talk about it a little later. Yeah. So this is a thick and thin smear, and you stain it with Giemscha stain, the peripheral blood smear, and you find the trophozoites or whichever stage you find. So when you're making the thick and thin smears, is generally recommended that you make both the thick as well as the thin smear on one slide itself. Otherwise, what happens many a time is that since if you've got lots of cases, they may get mixed up. A thick smear of one person may get mixed with a thin smear of another person. So it's better to have it on one slide. Okay. We already talked about it. Sensitivity is high, possible to detect parasitic low densities. We already talked about this. Okay. Now, the antigen detection kits, which are the rapid detection tests. So, National Vector-Borne Disease Control Program, NVBDCP. Please remember this. We'll be talking about it in great detail afterwards, sometimes later. But at the present moment, please remember we do not have a malaria control program now. It is called a National Vector-Borne Disease Control Program. We're talking about all vectors we're going to control. Okay. This program provides the rapid detection kits for Plasmodium falciparum as well as combined. The Plasmodium falciparum kits are based on the HRP2 and the not the Vivex, it is combined for all Plasmodia is an LDH or Aldo's screening. So aldolase. So this as the plasmodium secretes aldolase, you can detect it, and then you can possibly make out that whether the person has got malaria or not. Shelf life is generally about 18 months and can detect parasite till 3 weeks time. The HRP2 based kits show positive results up to 3 weeks. That is what we just said. That is for Plasmodium falciparum. Now, when you make the diagnosis, you have to consider the epidemiological diagnosis. You have to consider where the person was, how did he manage to get it, whatever is the agent and the host and the environmental factors which are involved. The clinical diagnosis and a lab diagnosis, which we did with a thick and thin smear or a fluorescent antibody or a dipstick test. Now, epidemiologically, you have to do measurement of malaria. We already talked about it, just a run through of it. The classical measures are to do a spleen rate, that is measuring the endemicity of malaria in the community. You have children about 2 to 10 years. So you take the average and large spleen, parasite rate, and the parasite density index. These are the three things which you normally see. Or you can also see the infant parasite rate, the most sensitive index of recent transmission. There is the infants, you see, people may be harboring the Plasmodium vivax earlier, and they may be detected if they are adults or they are. But an infant who's just come into the world, he cannot possibly have it earlier. So that's the reason why it's the most sensitive index of recent transmission in the locality. And proportional case rate of proportion of clinical malaria to all the cases. This is another way of finding out. The most important indicator is the annual parasite index. Please remember this annual parasite index and annual blood examination rate. These two things are nowadays considered one of the most important indicators of malaria. So, the annual parasite index is confirmed cases in 1 year divided by the total population under study multiplied by 1,000. We already spoken about it earlier. We classify the whole country into different stages, less than one, more than one, depending on the annual parasite index. And if the annual parasite index is high, then we put in extra measures to control the disease. The annual blood examination rate then generally gives you an idea as to whether the whether we are doing a proper surveillance in the area. If like in COVID, you don't do the test, you will not get positive. So similarly, in malaria, if you don't do the test, you will not get positive. So the number of slides examined divided by total population gives you the annual blood examination rate, which is very important. Also, the annual falciparum incidence also requires to be seen. The vector indices which are there: human blood index, porozoite rate, mosquito density, man-hour catch, man biting rate, and inoculation rate. These all are various measures by which we measure how high is the vector, what is the vector index. You see, in human blood index, what we're doing, we're taking mosquitoes, take all the mosquitoes which we collect, catch, then we kill them. We consider how many of them have got human blood. So that's human blood index. And then we dissect the mosquito and look for sporozoites. That's the salivary glands of the mosquito. That is the sporozoite rate. Mosquito density is you keep a person with hardly any clothes and then you see how mosquitoes sitting on him, you catch those mosquitoes. So that is the man hour catch rate. Or you can catch these, or if just see how many are biting him in man biting rate. And inoculation is how many of these mosquitoes. Um, this is actually a calculated figure, inoculation rate, with the man biting rate multiplied by the sporozoite rate. So we will talk about the management of malaria cases and then we will talk about the vector control. Okay. So first is management of the malaria cases. What we have to do is we have to train our healthcare workers. We have to detect early and treat the patient early. We should have good referral services, and we should have places which we call the DDCs, that the drug distribution centers, and the forward treatment depots for treating malaria cases or various other cases which are there. Also, we now at the present moment have early case detection, complete treatment, and sentinel surveillance. Sentinel surveillance means that particular organizations which are looking at or particular area which is looking at specifically at malaria. Integrated vector management is carried out, and epidemic preparedness and early response should be there, and supportive interventions like behavioral change. That means people should understand that they should have to take personal protective measures. They have to stay under mosquito net, or they have to ensure that the wherever they've excavated is covered so that water collection don't take place. Capacity building, more trained manpower, monitoring has to be carried out. Intersectoral coordination between the engineering segment as well as the medical segment as well as various other segments so that we do not have mosquito breeding, construction sector, etc. Evaluation of programs should be done. So we started the National Malaria Control Program in 1953, and then we went through malaria eradication, but we were over enthusiastic at that time. We didn't do enough, and so we landed up with more malaria after the 60s. In the 60s, after the 60s, we got huge amount of malaria, and then we changed our plan to a modified plan of operation 1977. And then when cases have started coming down again, we are now moved to a national vector-borne disease control program in 2002. Okay. What are the treatment for uncomplicated malaria? Let's just jump to it straight. The treatment for uncomplicated malaria is chloroquine. Chloroquine 25 milligrams per day. Sorry, 25 milligrams total dose. And this is given, you give, do we have that slide? Yeah, we've got the slide here. So what you do is you give 10 milligrams per day on the first day, 10 milligrams per day on the 10 milligrams per kg body weight on the first day, 10 milligrams per kg body weight on the second day, and 5 milligrams per kg body weight on the third day. Now, this, if you see, works out to 4 tablets in case of adult patient. 4 tablets on first day, 4 tablets on second day, 2 tablets on the third day. This is how we must carry this. Primaquine is which the chloroquine is being given. We are giving chloroquine basically for all the stages of which are there in the um, which are there in the bloodstream, as well as the hypnocyte stage which is there in. So for that's the reason why we are now, as far as relapse and prevention is concerned, we are giving primaquine. Primaquine kills the hematocytes as well as looks at the hypnocyte state. So that we give 0.25 milligrams per kg body weight, and that works out to about 15 milligrams per day for 14 days. You're supposed to give for 14 days because the hypnozoids will remain in the system and we will have to kill those hypnozoids. So that's why for 14 days we're giving 15 milligrams per day. And I'm talking about adult dose. And so 15 milligrams per day for 14 days. Primaquine is contraindicated in pregnant women. Just a minute, let me get this into the. Yeah. Primaquine is contraindicated in pregnant women, infants, and known G6PD deficient patients. The primaquine can lead to hemolysis G6PD deficiency and should be advised. Patients should be advised to stop primaquine immediately if any of the symptoms take place as dark colored urine, yellow conjunctiva, bluish discoloration of lips, abdominal pain, nausea, vomiting, or breathlessness. Then primaquine should be stopped. Now, what do you do in cases of falciparum malaria? Falciparum malaria, you do not, please remember, chloroquine is only and only for Vivax. In India, for falciparum malaria, you will give artemisinin combined therapy, ACT, artemisinin combined therapy. So artemisinin derivative, long-acting ones, amodiaquine, lumefantrine, mefloquine, piperquine, all these things are being used. But what do we use in our country? Our country, what is standard treatment is artesunate, 4 milligram per kg body weight for 3 days, and a sulfadoxine pyrimethamine combination. Sulfadoxine 25 milligram per kg body weight, and pyrimethamine 1.25 milligram per body weight. You know, generally, it is. We generally refer to all this as AS-SP therapy. The AS, that is artesunate and sulfadoxine artesunate and sulfadoxine pyrimethamine combination. So this is given at day 0, and primaquine, for a single dose of primaquine, 0.75 milligram per kg body, that comes to about 45 milligrams, is given on day 2. So this is what we give. Please look at the last row, 15 and above. That is, you're giving artesunate 1 tablet. You're giving sulfadoxine and pyrimethamine. You're giving 2 tablets, and on the second day you're giving 1 tablet of artesunate and primaquine, 6 tablets, that is 45 milligram. Third day you're only giving artesunate. So 3 days you will be giving artesunate. The sulfadoxine pyrimethamine combination only on 1 day, that is 2 tablets on the first day, and on the second day, instead of this SP combination, you're giving primaquine, 45 milligrams of primaquine. Third day, you're only giving artesunate. However, the treatment in Northeast is a little different. Because of the failure of artesunate and SP therapy, which is there, we require to give a different combination. And the different combination which we have is artemether-lumefantrine combination. Artemether-lumefantrine combination. And that is given in the Northeast. Okay? In here you have a artesunate, sulfadoxine, pyrimethamine combination all over India, except Northeast where you have artemetine, lumefantrine combination. Monotherapy of oral artemisinin derivatives is banned in India. Please remember that. Injectable artemisinin derivatives should be used only in severe malaria. So ACT should be given for treatment of plasmodiaphragm malaria in the second and third trimester of pregnancy. But in the first trimester, you don't give ACT, you give quinine. Plasmodium vivax, we said already, treated by chloroquine. Mixed infection of falciparum and this thing, then what do you do? In that case, again, ASSP combination is not effective. So you will be using the other ACT combinations which are there. Primaquine, of course, will continue. Primaquine in a combined Vivex and falciparum, you would take primaquine for 14 days. Okay. Treatment based on clinical criteria without lab confirmation. Sometimes lab confirmation does not take place, but clinically you find a person with fever, chills and rigors, seems to be malaria. You will count him as clinical malaria and give him treatment. The general recommendations for uncomplicated malaria is to avoid starting treatment on empty stomach. First dose to be given under observation. Dose should be repeated if vomiting within half an hour because the drug would not be absorbed. Please remember, chloroquine is a drug which is very irritating to the gastric mucosa. So it's better that the person eats something and then has the tablet. Patient asks to report back if no improvement after 48 hours or deteriorates, then you investigate for concomitant illness. So this is all that we have discussed earlier also. We will not, I think, don't need to go through this. Now, when is a patient considered to have a treatment failure or drug resistance? Patient is cured if there is no fever or parasitemia after 28 days, because otherwise you can have a recurrence or a relapse. Patients may not respond to treatment due to drug resistance or due to treatment failure. So early treatment failure is when development of danger signs on day 1, 2, or 3, and the parasitemia is very high on day 2. Late clinical failure is when the development of danger signs takes place later, that is 4 to 28 days. That's late clinical failure. Late parasitological failure is when parasitemia is there on days 7 to 28, plus temperature, and plus it just does not meet the criteria of early treatment failure or late clinical failure. That is the time we call it late parasitological failure. So we had first we had late treatment failure for 1 to 3 days, 4 to 28 days with danger signs and parasitemia. You have late clinical fever failure, late parasitological failure. You have when um, you have parasitemia on days 7 to 28, and temperature is also high. Treatment is ACT or quinine with doxycycline. Doxycycline is contraindicated in pregnancy, lactation, and children up to 8 years. Now, what do you do in severe falciparum cases? In severe falciparum cases where there is impaired consciousness, prostration, multiple convulsions, then we call it severe falciparum. Or you have acidosis, a base deficit of greater than 8 milliequivalents per liter, bicarbonate level of less than 15 millimoles per liter, or a plasma lactate of greater than 5 millimoles per liter, respiratory distress, or a hyperglycemia which is there, or a severe malaric anemia, where you have hemoglobin less than 5 or hematocrit greater less than 50. Then you can have renal impairment, creatinine high, blood urea high, jaundice where you have the cerebrobilirubin high, or the parasite with parasite counts were high. Or you can have pulmonary edema where the oxygen saturation can come down, the respiratory rate can go up, then there are crepitations present. You can look for significant bleeding, which is possible in starting of DIC, and recurrent prolonged bleeding from nose, gums, or venipuncture sites. Person can go into shock, or there can be a hyperparasitemia. The plasmodium parasitemia greater than 10% can block various We can have various problems with that. Now, what are the clinical features which we have? We have impaired consciousness, coma, convulsions, renal failure, jaundice, severe anemia, pulmonary edema, and hypoglycemia. Now, what do you do as far as the summary of these conditions which are there? We can have acidosis, collapse, abdominal bleeding, hemoglobinuria, hyperparaxia, or hyperparasitemia. So all these are features of clinic severe malaria. What do you do in these cases? You give parenteral antimalarials, antipyretics, antibiotics, anticonvulsants. You have to give the personal intravenous infusion, special nursing for coma patients, blood transfusion, lab facilities should be available, and facilities for oxygen, dialysis, and ventilator should be present. Please remember that falciparum malaria many a time does not give you time. I've seen people who have been when I was posted in the Northeast, I have a number of postings in the Northeast. You find a person on guard duty, and next moment you are told that he is dead because the guard commander did not bother when the patient said that he had fever. He should have, the moment he has fever, he should have been brought to the medical officer should have been informed. Falciparum malaria is a very short duration and can create a lot of problems at that time. Artificial derivatives of quinine should be used. You've got various things which are there. Artesunate or quinine. Quinine can be given at 20 milligrams per kg, and the maintenance days of 10 milligrams per kg, 8 hourly. Never give a bolus injection. Please remember, never give a bolus injection. We could also give artemether and arteether. These depends on what the plasmodia is sensitive to. We use ACT containing mefloquine for cerebral malaria due to neuropsychiatric complications of other drugs which are there. Sorry, mefloquine is avoided in cerebral malaria because of neuropsychiatric complications. And any case who is of severe malaria or Vivax, we should then start thinking of using the same drugs as we're using for falciparum. So this is how you can manage coma, hyperpyrexia, convulsions, hypoglycemia, acute pulmonary edema, acute kidney injury, spontaneous bleeding, and coagulopathy. All these can be treated by good nursing and medical care. Now, we come to another important question is whether we should take chemoprophylaxis. We in the armed forces have been taking chemoprophylaxis since ages for malaria. And as far as the civilian population is concerned, chemoprophylaxis is good for travelers, migrant laborers, military personnel, and those in highly endemic areas. When I went to Africa recently, I can't say recently because COVID is there recently. Yeah, I went about 2 years ago, and I was on chemoprophylaxis for malaria there also. So if it is short term, person is going for less than 6 weeks, then all that you need to do is use 100 milligrams per day of tetracycline. Should start it 2 days before travel, till about 2 to 4 weeks after leaving the area. But this is contraindicated in pregnant and lactating women and children less than 8 years. As a long term, if a person is going to, like in the armed forces, we stay for more than 6 weeks, then we use mefloquine, 5 milligrams per kg, maximum of 250 milligrams weekly, and should be started 2 weeks before and stop 4 weeks after leaving the area. Contraindicated wherever there are convulsions or neuropsychiatric problems. Okay, just a few words on vector control. We will talk about it in detail sometime later. Please remember the vector control or control of the mosquito can be either adult or where it is personal, where the mosquito is breeding. In adult, we have residual sprays where the strategy is controlled by the National Anti Malaria Program or National Vector Disease Control Program, and DDT, BHC, malathion, fenthion are used. You can use space sprays where you have ultra low volume fogging, which can be done, or individual protection can be done through screening of houses and insect repellents. Anti-larval measures that we use are either larvicides, chemicals, biolarvicides, larvivorous fish. Then we can reduce the sources through removing breeding sites, intermittent irrigation, or drainage. Basically, what we require is an integrated vector control program. And we did have a rollback malaria launched by the WHO. Various programs have been using, but now currently we, as I said, now we are under the National Vector-Borne Disease Control Program, and this program has got all these measures as listed, which I've listed over here. We will talk about it in detail sometime whenever we have the time for it, and I will end over here. Um, Basically, malaria is a huge topic. I've tried to cover it in 2 lectures. Please read through it. If you have doubts, I've already told you. If you have doubts, please send me a message in WhatsApp. I do not look at the messages on YouTube. I repeat, I do not look at the messages on YouTube. Please send me a WhatsApp message and then I'll be able to clarify your doubt. Okay? All the best and have a good time. Stay safe, stay healthy.